It's my pleasure to introduce the next speaker, Dr. Steve GOLDSTEIN. Steve is in the same club that Randy and I are. I think he's a younger member of that club. Yeah. And he's a spectacular teacher. He's a wonderful clinician. He's been in the echo world for as long as I guess many of us have been, and has a wonderful way of explaining things. You have it, right? We're also very grateful that he took this topic, because it's not a topic that many of us want to take. As you all know, the right ventricle is still a challenge, and clearly an area where CMR has made some big impact. But in the echo world, we look at a lot of right ventricles, and we had to make decisions on how the RV functions. So Steve is going to help us with that.
Thank you very much, Mike. While I was hooking up here, I heard you say something about age. We'll come back to that in a second. This medical center, by the way, is phenomenal. I think there's nothing else like it in the world, and I mean that. This is a city within a city, and your hospital as a part of that is really phenomenal. I've visited a lot of places, Mayo Clinic, Cleveland Clinic, Mass General, to name a few, and your facilities are just marvelous here. But I do want to go back, because you didn't always have the best facilities in the world. This is when Mike came. This was truly Methodist. This is Methodist Hospital many years ago when Mike came on board. And then he recruited Dr. Zoghbi a few years later, the 1950s. So this was before this complex really grew up, et cetera, et cetera. Well, we're going to turn to the right heart, and there are several sources that I think are very key and very important for all of you, sonographers, fellows, clinicians, echocardiographers, et cetera, other imagers to be aware of. One of them is a little bit earlier now, and that's the right heart guidelines paper. Larry Rudsky was the key author a number of years ago, about 7 or 8 years ago. More recently, Roberto Lang in the American Society's cardiac chamber guidelines with slightly revised data on some of the right ventricular things. And then we'll touch on at the very end, because I was asked to touch on tricuspid regurgitation, the valve guidelines that were published 3 or 4 years ago, Rick Nishimura, et cetera, et cetera. Now, all of you know that the right ventricle is a problem for many, many reasons. Primarily, its complex shape. Unlike the other chambers that are sort of elliptical or round, et cetera, are close to geometric shapes, the RV is a bit of a problem. It's got an inflow portion, a body, and an outflow portion, illustrated both by angiography and a diagram. So it's non-geometric. It's right near the chest wall, and that creates some imaging issues for us with our transducers and near-field issues. We frequently tend to, and it's hard to overcome, foreshortening the right ventricle. Seeing the endocardial borders are tougher with the RV than the LV, et cetera, et cetera. So these are some of the problems that make the RV difficult. Now, this whole session is supposed to focus on heart failure, so I'll try to weave the RV into heart failure a little bit, but I do want to talk about some technical issues as well. First of all, RV dysfunction often occurs in both ischemic and non-ischemic heart disease. It's a little more common in non-ischemic. It's very, very strong predictor of events and mortality, perhaps even better than the ejection fraction. All of us know Mr. Smith, who has an ejection fraction of 20%, and he can do construction work, climb on ladders, use a hammer, lift pounds of materials, et cetera. And then Mr. Jones, who has an EF of 20%, and he can barely walk across the room. So the ejection fraction by itself has some limits, and part of the reason for that is the right ventricle. So what I'm going to try to sell you on a little bit is that the RV is the tail that can wag the dog. In other words, more important in many cases for both symptomatology, and for prognostication. This is a list. It's a little small to read, but some of the settings in which the RV has been demonstrated, usually in more than one study, in multiple studies, in all of these entities, to have prognostic value. And obviously, in a short 15-minute presentation, I can't go into all of those, nor do I plan to. For the sonographers in the room, we typically have a handful of windows that we use when we assess the RV. I think we shouldn't be limited to those. This is from the American Society of Echoes paper, and you see there's a whole host of images when we use some slight hybridization, et cetera, et cetera. So don't stick just to the standard images. Often to get the RV, we have to do more. Now I'm going to whiz through these slides. I put them in only so that you would have them in your handout, but what I'm illustrating here by color is that portions of the RV correlate in different views, and I'm not going to spend time on them. I'm just going to go through them, but they're in your handout, or the handout that you'll receive that I've given on my little stick, etc. Now, what should we be doing in our echo labs every day? These are the things that I think should be done routinely. Measure the RV size in some fashion, the RA size, and I'll come back to that in a minute, and some assessment of systolic function. I'll dwell on this in a moment, but in addition to simply eyeballing the LV, which has been deemed to be inadequate, you should be doing something else. We do these latter two routinely, and I'll explain why in a few minutes. You should estimate systolic PA pressure needed for diastolic function. You've heard from Dr. Naga some of the reasons for that, and estimate RA pressure when possible from the IVC. And I'm simply listing the things that we do. We don't do routinely right index of myocardial performance, the so-called Tay index of the right ventricle, and we don't routinely do fractional area change, probably because they're a little more tedious, et cetera, et cetera. RV size can be measured in a number of ways. In parasternal views for the sonographers, the size will actually vary whether your patient is sitting up or lying down. The numbers are smaller in a supine patient than a larger patient, so just be aware of some of those kinds of things. And then where you make your measurements can make a big difference. So that if we put our cursor from the top right through the tips of the mitral leaflets, the place to measure the LV, that's going to differ. You can see that the diameter of the RV will differ depending on where you put your cursor. So the RV's kind of a problem in a number of ways. Trabeculations, the RV is more trabeculated than the left ventricle. I've already alluded to foreshortening. So these are some of the particular problems. And this is a big one, and that is getting the so-called RV-oriented apical four-chamber view that the ASE recommends us to do. It's not a piece of cake, quite frankly, and often we tend to kind of use the standard four-chamber view, and if you do that, your measurements of the diameter of the RV will be your normal values will be slightly smaller than if you get a truly RV-oriented view as illustrated here. We do look at, and I use this dimension sometimes because reference to a big LV, sometimes the RV may appear small, but if you just throw your cursor on there a little bit, you'll sometimes get surprised that you've got a 4.8 or a 5.2 centimeter right ventricle when it looks small because it's sitting next to a globular and dilated left ventricle. These are the numbers from the ASE, and as I've mentioned, when we don't have a proper view, I tend to lower these for my own interpretation, usually to about 3.6 upper limits for the RV if I don't have a proper RV-oriented view. Getting back to heart failure, the theme of this, simply measuring RV size does have prognostic value. If you look at patients with idiopathic dilated cardiomyopathy, normal size RV versus big RV, big difference in survival in study after study after study. I'm showing you a few older ones, but the same thing in more recent studies. Right atrial size is a little bit of an issue. We don't have quite the normative data for volume yet. I tend to use area, and the ASE suggests that area of over 20 centimeters squared is a good partition number. They do give some volume numbers, but they do point out that they're not very well established. So we stick to area for the right atrium, et cetera. And there's prognostic data in the right atrium. Simple chamber like the right atrium. Look at the difference here. These are patients with chronic heart failure, low EF, 1 year all-cause mortality, small, or not necessarily small, but smaller right atrium versus larger right atrium, big difference in survival. RV function is an issue. The right ventricle is very different from the left ventricle. The left ventricle is used to high pressures, etc. A high resistance situation. The RV is used to low resistance, the pulmonary circuit, and is a very different chamber. The LV generally contracts in a number of different ways. The RV largely is shortening in a longitudinal sense. This is the major way that the RV ejects its blood. So the base moves down somewhat like a piston, although it's a little more complex than that. There are several ways that the RV contracts. The most important, though, is the one that I've mentioned, contraction along its long axis towards the apex, the so-called TAPSE measurement, if you will. But it does have circumferential, radial shortening, and the septum, which is shared with the left ventricle, bulges into the cavity and does participate to some degree in ejection of the blood as well. I've already mentioned that a visual assessment of the RV is inadequate. The ASE recommends that we add to that some other parameters that I've outlined here and some a little bit less common entities and something that will be increasing in use and probably value over time. We do these two that I've highlighted, and I'll illustrate why. The feasibility is very high with TAPSE and with tissue Doppler S prime. It's not quite as good with some of the other parameters. Fractional area change is not a piece of cake in the RV for a variety of reasons. These are patients on ventilators with ARDS, and look how easy, even when image quality is poor, we often get a good TAPSE and can get a good S prime. A few comments about TAPSE, which is simply motion of the tricuspid annulus towards the apex, longitudinal shortening of the right ventricle. It's easy to do. It's an M-mode parameter, and we measure it from the nadir to the peak. There are often multiple lines. You can't take one set of lines and then go up to the next. You've got to keep the same line when you measure TAPSE. Very easy to do, but reflects only longitudinal shortening, and sometimes it's not a perfect entity. These are listed some limitations. I won't go over them, but I want to illustrate here that there are some patients in whom TAPSE may be good, shown in this upper left-hand square. This is TAPSE versus fractional area change, and fractional area change is not so good. So there are patients that have mixed numbers. Conversely, there are patients who have TAPSE that's abnormal and fractional area change is good, is shown here. So it's useful, but don't hang your hat on that simple number. Put everything together. This is illustrating ejection fraction by cardiac MR and TAPSE. The correlation is not fantastic. There is some correlation, but it's not a perfect value. Don't use it by itself. And lastly, this slide illustrates that TAPSE depends also on the left ventricle. This is a patient with normal RV and LVEF, and you see that TAPSE is a very high value. If you throw into that bad LV, TAPSE, although still falling perhaps into a normal range, is a little bit lower, et cetera, et cetera. So TAPSE does depend in some part on the left ventricle. The number was revised slightly. The newest guidelines, your TAPSE number is 1.7 centimeters. TAPSE has prognostic value in heart failure, idiopathic or ischemic, relatively normal TAPSE in this group's data a number of years ago versus lower TAPSE, survival, big difference. And I can show you a number of studies. I'll just go over them quickly. where TAPSE is normal or abnormal and has importance. Fractional area change, I've already alluded to a little bit in some of the problems in measuring it. Part of the reason that we don't do this routinely, it's tedious, time-consuming. Finding the borders is not always a piece of cake, but it's sort of a poor man's RV ejection fraction, if you will. Normal value, less than 35%, et cetera, et cetera. Fractional area change also has prognostic value. This is in patients after myocardial infarction, and you can see that without RV dysfunction versus with survival, et cetera. Even in HFpEF, even in, quote, patients with normal systolic function, RV function with fractional area change has prognostic value, so keeping to the heart failure theme. This is a very simple parameter, again, to obtain. We simply put our tissue Doppler at the tricuspid annulus, and we're looking at this portion. This is isovolumic contraction. That's not the number that we're measuring. We're measuring the systolic. This patient is abnormal, a little bit on the low side, but notice there's a little variability here in this patient with atrial fibrillation. So you have to be careful with rhythm, et cetera. And normal value was changed a little bit in S prime, just a touch moved downward from the 2010 to the 2015 guidelines. Going to skip a few slides. Prognostic value in S prime also. Heart failure patients with EF less than 35%, with normal S prime survival nearly normal, quite good, versus low S prime. RIMP, I'm going to skip a little bit for time's sake. This is a compilation of both systolic and diastolic function, and for time I'm going to skip it, but I've left those in for your handout, purpose of handout. And a lot of data coming in now for strain. You heard earlier a nice discussion from Dr. Quiñones on LV strain. RV strain has value as well. We're still kind of evolving. Do we do global strain as illustrated here, which includes the septum, as I've shown you here, or do we do free wall strain and not global strain? So those are some of the issues. We're still working out normative values, et cetera, et cetera. So I think it's something a little bit down the line. There are some limitations to strain in both the left ventricle and right ventricle. There is good prognostic value in strain as well, as listed here in this slide. All-cause mortality in patients with pulmonary hypertension, a large number of patients, and as strain gets worse and worse, this is better, and as it gets worse, mortality is higher with strain. Data from a different group, patients with chronic systolic heart failure, low EFs, and this is adding, looking at just clinical features and prognosis of patients with heart failure, adding in ejection fraction, and then adding in strain. There's incremental value to using RV strain. More data, not time to go into it in detail with strain. I've already alluded to the importance in prognosis with most of the parameters individually with you, et cetera, and I'm going to finish. I was asked to touch on TR as well. These are large, this is a large number of patients. This data comes from University of Michigan about 15 years ago. Patients with systolic dysfunction, severe mitral regurgitation, and look at not significantly different amount of coronary disease, atrial fibrillation. The EF is a little bit different, does make statistical significance because of the large number, but a major jump up in presence of severe TR in patients who have MR. We used to feel, it used to be said that patients with TR would get better once we improved mitral regurgitation or LV function. We've learned more and more now that that's not the case. We probably should be dealing with tricuspid regurgitation. This is the number of patients that are felt, a huge number of patients that are felt to be undertreated by patients in this country with tricuspid valve disease who are actually having it managed when they're having concomitant surgery. And to end, just some of the data, a couple of papers that are stating the same thing, that we should we should not ignore tricuspid regurgitation. It also has prognostic difference. And two different guidelines, the AHA-ACC guidelines recommend surgery on the tricuspid valve, certainly with severe TR, class 2A in patients, and even with moderate, mild, moderate, or severe. So even potentially with mild, if you've got significant tricuspid annular dilatation or right heart failure clinically, this number varies from 4 to 4.5, 4.3, depending on who you read for the annulus, but as a class 2A recommendation for surgery. And the European group also recommends addressing the tricuspid annulus in patients undergoing left-sided surgery. Thank you very much.